Distinguished faculty, esteemed colleagues, and dear friends. It's my privilege to welcome you all to this month's session of the IMS Cure Summit highlights, organized jointly by the faculty from the International Myeloma Society, the International Myeloma Foundation, and our very own Indian Myeloma Academic Group, the IMAGE. Today's program brings together some of the most respected global leaders in myeloma research to give us snippets on what transpired at the Cure Summit held on February 20th, 21st in Miami, Florida, USA. The theme of the cure in myeloma is not merely aspirational. It reflects a rapidly evolving scientific landscape, one in which long-term disease control and functional cure are becoming realistic goals indeed. Today we have participants who have tuned in from over 22 different countries listening to our discussions. And over the next, over nearly 1.5 hours, we will journey through the landmark analysis, regional perspectives, and future collaborative pathways. Each talk has been carefully curated to give us a comprehensive understanding of where the field stands today and where it must go next. I encourage all participants to engage actively, reflect deeply, and consider how each one of us can contribute to this collective mission. With that, let us begin today's session. I'd just like to read out the agenda which has been sent to everybody. We have the IMS definition of cure, which will be, I will introduce the speakers, but I'll just highlight the topics by Dr. Nikhil Munshi, then highlights of IMS Cure Summit and Landmark Analysis 5 and 10 year of Indian myeloma patients by Colonel Uday, and then the Indian perspective of cure in myeloma by Dr. Pankaj Malhotra, and the Asian perspective of cure in myeloma by Dr. V. Jo. And the 5 and 10 year landmark analysis of the Asian multi-country database by Dr. Chandramouli from Singapore, and studies to be planned in Asia in line with cure in myeloma, which will be present by none other than Dr. Shaji from Mayo Clinic. Now, I would just like to say that the first talk by Dr. Nikhil Munshi is indeed the foundational talk, and he needs no introduction to this forum. He's been there so many times, but in the traditional way, I would just like to highlight that he's one of the leading lights in this domain of multiple myeloma, and he's the Director of Basic and Correlative Science in the Jerome Lippa Multiple Myeloma Cancer Center, and also of the Multiple Myeloma Immune Effector Cell Therapy, and a professor of medicine at Harvard Medical School, Boston. So with that, I would invite Dr. Nikhil Munshi to please deliver his first talk on the IMS definition of the cure, which is we're all waiting to hear. And I would request the speakers, in the interest of time, to just stick to the time portfolios allotted to all of us. Thank you very much. And once again, welcome to this very important meeting. Dr. Nikhil.
Thank you so much, General Nair, for this introduction to the topic and my introduction. And it's really great to be here, and also for selecting this topic for discussion, because it's been one of the missing piece in myeloma, as you would see, and as we will discuss in a minute. So we had this meeting in Miami by our society to discuss and decide what would be a cure in myeloma be like. And the reason, are you seeing my screen?
Yes.
Yeah. So the reason we needed to meet and reason we are meeting today is what has happened in treatment of myeloma and outcomes of patients with myeloma. For many years, myeloma was first described in mid-1800s, and it was, of course, uniformly fatal. And for 150 survival curve, the plateau happens at a different time points. They're not all at the fixed time. You could see it at 3 years, 5 years, even longer. On the myeloma side, this is the curve we have been used to seeing it till recently. Now we are beginning to see where the curves, and this is partly artificially generated curve, partly based on some data, but we are beginning to see proportion of patients who are not dying or who are not relapsing following the treatments they have been getting. And these and similar other data set is being considered as should we look at it. Now, one of the important thing to keep in mind is that the debate was about if this fraction exists, how much that fraction is, and how do we predict that people would belong to that particular subset of patients. Now, one of the highlights of the discussion in this meeting and part of the genesis was that we always quote when you tell somebody, well, myeloma is curable or something such thing, everyone will say, oh, but I had a patient who relapsed after 10 years, or I had a patient who relapsed after 15 years. The point that became very clear in our discussion is that happens in every malignancy which we call curable. This was the example of testicular cancer, which we all know is curable in 90% of the patient. But even in this disease, the place where the arrows are, there have been relapses at 4 years, relapses at 8 years. So anecdotal, smaller proportion of patients may have relapses later on, but testicular cancer is still called curable disease. So we have to keep in mind this anecdotes cannot become the rule. And then we know in myeloma, there has been a consistent improvement in survival, both progression-free and overall survival. And the ultimate to achieving a cure, elimination of the disease, the best we can do is by measuring MRD negativity, that those rates are going up with the newer treatment. It has become 60, 70%. And this is the region where one would feel there would be proportion of patients who may not relapse. So all of the stars were aligning for us to discuss this. And then the critical question in our discussion was that to call a cure, we need 3 different domains to be aligned and agreed upon. One of them is biological, which means that we are not detecting malignant clone. We need to confirm that. The second is clinical, that patients do well without treatment and without recurrence of the disease. So long-term treatment-free survival is an important component. And then the third component is that statistically speaking, the curves show what we have been used to seeing in other curable malignancy. There is a plateau in the curve that we need to consider. So these are the domains which will provide a credible declaration of cure. And this is the starting of our discussion. And what we were charged with in our meeting was that we want to achieve this. And one of the important component is, which is also has been discussions at every level and with people with great expertise in myeloma. Well, there is a control. Why do we need a cure? And we can debate it here as well. The point is here we are discussing life without the disease. So yes, patients, there are lots of our patients. We all have many patients who develop MGUS-like state. But the purpose here is to eliminate the cure and existence without any clonal protein, any plasma cell. And that was the charge. We want that condition. We are happy with control if we don't get a cure, but not as a weaker definition. And we have to learn from the other people with expertise in other diseases, testicular lymphoma, this and that. And then important part of this meeting was that myeloma, it was the first community, believe it or not, to have a formal discussion to define a cure. We had experts from many diseases, and I can tell you who they were: from testicular cancer from Indiana, from Jim Armitage for lymphoma, the wonderful German colleague Berschmann for Hodgkin disease. They all cured their cancer. So we're learning from them, and we need a very rigorous evidence-informed definition. So, so the point was that we need to use our current state-of-the-art therapies, biologically and clinically defined, and look at the statistics, and then explore the integration of all this to come up with a definition. And just the point below was that there is an increase in talk about cure in myeloma. I won't go through the meetings, the discussion, I do not have a marker for my time, so I don't know I'm slow or fast. Please remind me. But the point ends up being that we had a lot of data presented by all various group in the first 4 hours, all group with long follow-up to understand what we did before. And then we had what should be called a cure, and this is where we define what would we think is a current definition should be. Then there were discussions about patient subgroups who might be more inclined to be cured. And then patient voice was critical component. What do patients think? That was one of the most touching session of what it meant to patients when they are told that, well, you might be cured. And then we learned from the other malignancies that there was a hug of contagion, talked on leukemias, etc. And so that was very insightful group of discussion for us to learn from them. The last session was where we were looking at what are the curable concepts, which treatment we think today might cure the most patients or get us the best. And that was also very meaningful. And then we had a conclusion. So I'll just go to very quickly some of the data, and I'm not going to go into the details. You just see the curves. That's all my purpose is for sake of time. But a lot of people discussed the data, and you could see that when we looked at this patient, and these are all either progression-free survival, not overall survival. That's not as important. Patients should not relapse. And the progression-free survival curve you could see, this is from GEM 2000 study, got old-fashioned treatment with transplant and interferon maintenance. Proportion of patients are not relapsing beyond 10 years and out. This is myeloma 11 study, very beautiful study from the British group. It shows the plateau in the curve, and the plateau goes up with the age. So younger people had a higher chance of getting a plateau versus older people, 80 and 70 here. And the proportion of fraction less than 60 was 0.16%, and it increased. We had a wonderful discussion on some of the other studies where we are not seeing it at the earlier time point. Another GEM study, you could see the curves are flattening out in this patient population. If you look at more than 5 years treatment-free survival from CAR T cell, the curves here are not yet plateaued, but they are becoming flatter. And then finally, we had a wonderful discussion by one of the top statistician for myeloma. And he has begun to show that if you have 3-year, 4-year, 5-year sustained MRD negativity, Dr. Jagannath presented this data, so the flat line at the top, and that may be people not responding, and this is a PFS probability. And using the real world data from Arkansas study for many years, which we were lucky to be part of in early 90s, you can see the curves going up. The cure fraction from 6% was becoming around 25%. So this was the whole group of data. I'll just give the final results of what we concluded and what we agreed upon as a consensus. So the proposed definition of cure, that patient could be either newly diagnosed or relapse, doesn't matter. They must achieve a sustained complete remission by standard criteria. They must be MRD negative at 10 to minus 6 sensitivity by either of the method. And MRD negativity needs to be sustained for 5 years without treatment, without any therapy, irrespective of length of previous MRD negativity. While on treatment, you could be MRD negative, fine, but there should be 5 years without it. And there should be at least 4 MRD assessment during those 5 years, the last one being at the 5 years and nothing positive in between. So that's strict definition. And by functional imaging, either PET-CT or diffusion weighted imaging, at least at the beginning of 5 years and the end of 5 years, they should be functional imaging negative. That's our definition. There was also a proposal that we should study other parameters so we can improve upon this or make it easier. So we will continue to study mass spec band method. We will study circulating tumor cell. We will look at immune recovery, etc. But those are not yet to be included in our definition. And so finally, what we believed is that there is the cumulative data suggests that currently on an average, the cure ranges between 5 to 30% depending upon various features, patient age, patient's treatment, the risk features, etc. These numbers are therapies utilized 10 years ago. So probably this number may be higher today. We don't have that follow-up yet to be certain. And there's been ongoing work on that. And the final slide, is that the cure fraction varies according to therapy. We have to keep it in mind. The age impact of the age and the higher disease may be associated with lower cure. Again, needs continued follow-up. So the final slide is that this is what we were lighting in our paper. All of you have done it. I have done it. We will. First line of our paper would be myeloma is an incurable malignancy. What changes now in our mind is that we are beginning to talk more about cure. This is a PubMed from early 1950s to late. We talk more about cure. And so from now on, what we told everybody, the first line in your manuscript should be that myeloma is a curable malignancy. And the details goes there. So I would stop there and let's have discussion. Thank you so much.
Thank you. That was wonderful. That was enlightening. And how a perception can change the landscape totally upside down. So all the first paragraphs in the future articles will hopefully change and change for the better and bring more hope to such a large number of patients. So we will have the Q&As, after a few more talks. So the next talk is on the highlights of IMS Cure Summit and Landmark Analysis, 5 and 10 years of the Indian myeloma patients by Colonel Y. Uday, who everybody knows, who's the dynamic secretary of IMAGE and also is a professor of medicine and hematology at the prestigious Armed Forces Medical College, Pune. Colonel Uday, please.
Thank you, sir. So I would be presenting my slides on the Indian patients 5 and 10-year landmark analysis. So a snippet of this was presented at the IMS Cure Summit as well. So before I go ahead with this results which I'm going to showcase. So we had taken not all the institutes which are participating with the IMAGE database. We have taken only 2 major institutions, that is Armed Forces and the PGI Chandigarh data to analyze this. And as a first filter, we had put in those patients who had achieved complete response or stringent complete response. And as a filter 2 for the landmark, as Dr. Munshi has just elucidated, all those who had a progression-free survival for more than 60 months duration. And so we had a group of people who had sustained remission, and we called it as a sustained remission group. And we conducted the landmark analysis. Now, before we get into the results, we need to understand something. So when we are talking about patients with 5 and 10 years survival, that means we are looking at those patients who are actually treated in the early 2000s for this particular disease, or 2010 to 2015 for this particular disease. So the availability of drugs in the country at that particular time was much more archaic when compared to what we have currently available in the Indian markets. So this is a geographic distribution of the patients with gender male predominant population that we had. And there's obviously a referral bias to the tertiary care centers in the National Capital Region and Chandigarh, so the 2 union territories. So this is a distribution of the age of this population, wherein we had the peak incidence of 60 to 70, whereas we had a substantial population who were aged between 20 to 60 years, and approximately 40 to 50, we do have some peaks here. And in fact, we from our country have around 7 publications on adolescent and young myelomas or published or presented from various institutes of this country. So that's one highlight wherein which shows that we have a good substantial young population wherein we can really talk about this cure concept in the future with the changed way of managing those patients. Now, late presentation is a norm in our country, wherein the dominance is ISS 3. And when we look at the disease subtypes or the isotypes, is the IgG kappa, which predominates. And many of the patients, they present with end organ damage. We hardly have patients across institutes presenting with smolderings or with MGUS. It's primarily patients who come with end organ damage at the time of diagnosis. Now, you would also see in our database that there is a surge of patients between 2015 to 2020. This is primarily because of the establishment of IMAGE as a society, of creating databases, contacting various centers and trying to get the data from that particular area. So when we do a landmark analysis, having such surges of patients really skews the data sometimes or tries to misinterpret the information. And at that particular point of time, when we had collected the information, most of these patients were on BTD protocols. So with that information, let's go ahead and look at the 5-year landmark. So if we look at the PFS curves of the Indian patients, these are the PFS curves that we have. And what is the shaded phase is what we are going to discuss further. So if you look at these patients who have survived or who had a PFS of more than 5 years duration, they are those who actually came to the hospitals earlier. So on the left hand side, I have shown what is the general population, the stage 1, stage 2, and stage 3 ISS. And whereas on the right side, I have shown that the landmark survivors predominantly have stage 1 and 2 disease. So this clearly tells us that those patients who present early to the hospital have a higher chance of getting cured. Now, this is one concept which my mentor, Dr. Pankaj, used to keep reiterating ever and ever again, and the PGI has maximum number of papers on adherence. So the educational status, the economic status, and the adherence, they have a huge interlinkage. So we have found in the landmark analysis that most of these patients were actually graduates and belong to higher income tiers. That's showing that they had a higher adherence or a higher nutritional support. Again, PJ has recently come out with a paper this last time as they have presented a paper on nutrition and outcomes in myeloma. So these all have an interplay, and in countries, third world countries, these do make a huge difference. Now, those patients who achieved SCR or CR earlier in their part of the disease were those who were long-term survivors. So this is a corollary to what we are talking of MRD negativity in the current era, whereas when we are talking of 2015 to 20, at that time, or 10 to 15, we were not really having MRD tools across the country. So SCR and the CR dictated the long-term survival. Among the drug choices, VTD and VRD were the ones which had the highest amount of thing. So this clearly shows that people used to give doublets or other types of therapies or a cyclophosphamide-based therapy, but a triplet definitely had a thing. Now, if we do the same analysis 2-3 years down the line in India, we'd find that a quadruplet would definitely have a better survival. So for the 5-year landmark analysis, the 3 pillars that came out, or the triad which came out, was early detection of the disease, or early intervention into the disease onset, standard risk cytogenetics, a triplet induction, a SCR at the first response, those patients who achieved SCR at the end of induction, and those patients who had a better socio-demographic profile, had a better adherence, and thus had a prolonged PFS beyond 5 years. Now we extended this, and these are the clinical implications from the 5-year landmark analysis for the Indian scenario. So for those places where they still do not have a MRD access, or where the patient cannot afford MRD analysis, so target the stringent CR, supportive care is key, and early intervention is the key. Now, I would move gears, shift gears, and go on to the 10-year cohort. So we also analyzed those patients who had a progression-free survival beyond 3650 days. Though the tail is very small, but we do have some tail wagging there. So this is a place where we are talking about having a functional cure or a chronic control. And if you look at this decade-long cohort, so it clearly shows that the IgA patients did poorly vis-a-vis the IgG kappa patients. So this is again in concordance with what the international data talks about, triplet better than that of the doublets. So just to summarize the information, those patients who are in their 30s or 40s, they overrepresented in this 10-year cohort compared to the geriatric median, probably because those patients who who presented late had deaths because of other causes as well. So we really do not have a decade cohort for them. And continuous suppression. This is again one point which Dr. Pankaj keeps harping to all his students, that rather than just giving one transplant and leaving the patient, it's more important that those institutes which harp upon following up the patients for years together and maintaining some sort of suppression with a long-term maintenance is the ideal key in a country like India. And lastly, dynamic escalation. So with generics available now even in daratumumab, the people should look at quick switching to the further drug classes, THAL to LEN to BOTI to DARA, and even now with to bispecifics which are available in the country. So that would be the key for the survival in our country. So this is the last slide of mine of showcasing the summary of our survival curves and the 10-year decade cohort from the Indian data. We are going to analyze for the rest of the institutes and also incorporate some private institutes and get the redo analysis before this year IMS to understand how the cure matters in India. So with that, I would like to stop and hand it over back to the moderator, please. Thank you, sir.
Thank you very much, Uday. That was a quick, crisp, and brisk presentation where you did show us good Indian data covering both the 5 and 10 years. And we will now move on to the Indian perspective of cure in myeloma by Professor Pankaj Malhotra from PGI Chandigarh. All of you also know Professor Pankaj, who doesn't really need an introduction. Suffice it to say that he is an outstanding researcher and academician, and he's the distinguished professor and head of Department of Clinical Hematology and Medical Oncology at PGI Chandigarh. Dr. Pankaj Malhotra, please.
Good evening, good morning, everybody. Thank you so much, sir, for this kind introduction. Am I audible?
Yes.
Okay, thank you. So, what I am going to present is the Indian perspective of cure in myeloma. And actually, instead of Indian perspective, what we did was we did the survey of the SAARC countries and thought we present the SAARC perspective of cure in myeloma. And we also, just for the the residents who are listening to cure versus control, I think as Dr. Munshi said, previously we were thinking of myeloma as a controllable disease, and now we consider as curable disease. And one of the reason for that is that previously we just have steroids, chemotherapy, auto transplant, and now we have proteasome inhibitors, IMiDs, anti-CD38 antibodies, ADC, bispecifics, and CAR therapy. And that is one reason why we are now thinking of probably the cure of myeloma. But in low and middle income countries, we have a lot of challenges, and these challenges are related to the cost of treatment, the limited access, the urban-rural divide, and the cultural differences which we face. So when we talk of cure, we talk not only from the physician point of view, we also talk from the patient perspective. So what we thought was we took the survey of the patients, myeloma patients, and we did the physician survey. So first I would present the patients, myeloma patients survey. So this was a cross-sectional online survey and through the Indian Myeloma Academic Group. In the last 1 week, we were able to get access to around 175 multiple myeloma patients, and it is a 15-item structured questionnaire based on the patient background, perception of cure, life impact, and beliefs and influences of cure narrative. The eligible respondent in this patient survey was confirmed multiple myeloma diagnosis, any disease state, and it is India-based. So we have close to 134 responses from different patients, and almost when you look at the diagnosis, less than 1 year, around 20%, 1 to 3 years, 32%, 3 to 5 years, 16%, and more than 5 years, around 32%. And the current disease status, 12% of patients know that they are MRD negative status, 23% in complete remission. Some patients are relapsed. So these were the total respondents with the median age of 60.6, the age range from 34 to 83 years. So one of the questions was, how do the patients define cure? And according to the patient's perspective, most of the patients, around 50% of them, said disease never comes back. That is, how they believe that the myeloma is cured. Otherwise, many of the patients are living normal life. Doctor says disease is cured, no need for treatment, no disease in blood test, and no disease in bone marrow. So most of the patients believe that if the disease is never returning, then they consider this as a curable. Then the question was, how many years without relapse would make you feel cure? And again here, close to 50% of patients actually said entire lifetime. So the next question was, if you are in remission but still taking medicine, do you feel that you are cured? And again here, almost 37% of patients said no. If they are taking medicine, then they don't feel cure, even if you don't diagnose, even if they don't have the disease in their body. The next question was, how important is avoiding frequent hospital visits for you? And as expected, almost close to 60-70% of patients said that it is extremely important, very important, or moderate important that they avoid coming to the hospitals. Even if we say that these patients are cured, even then they have to at least visit 6 monthly or yearly to the hospital. Now, what matters most to you? And here the patients, most of the patients, said being able to work normally was the most important factor for them. Living without symptoms, living without treatment, and living longer were the other percentages. And financial stability was only in less than 5% of patients. Now, how important is reducing treatment cost for you? This is very important for the patients in the low and middle income countries. And as expected, almost 70% of patients said it is moderate to extremely important factor in reducing the treatment cost. Now, how important is being off treatment for you? Again, here almost close to 70% of patients said very important and extremely important if they are off treatment. So when we consider the definition of cure, this is from the patient perspective that they feel they should be off treatment. If your doctor says myeloma may never disappear completely but will stay controlled, would you consider that as cure? Here, most of the patients said maybe control disease but not cure, whereas 1/4 of patients said yes, they will consider this as cure. When will you feel free from fear of myeloma? And here, most of the patients said when the doctor says cured or after many years without relapse and when I stop treatment. These were the factors according to the patient perspective. Do you believe myeloma can be completely cured? Here, 50% of patients actually said yes, they believe that the myeloma can be completely cured, even though Dr. Munshi said about, we till date we are writing it is an incurable malignancy. Who influences your understanding of cure the most? So we just wanted to understand the patient's perspective. So here, 60% of the patients said, if the doctor says that you are cured, then they would believe that the myeloma is cured. So here, again, in the low and middle income countries, the physicians or the doctors play a very important part in understanding of the myeloma to the patients. So redefine cure conversations. Patient define cure primarily as permanent disease elimination, not just MRD negativity. And myeloma physicians should proactively discuss the MRD negative sustained remission as the closest clinical surrogate to patient defined cure. Treatment-free remission as a patient goal, 74% of patients rate being off treatment as very important or extremely important. And TFR endpoints and MRD adapted therapy de-escalation strategies are aligned with Indian patient preferences. And this should inform trial design and treatment goals. Addressing financial toxicity is again very, very important in low and middle income countries. And leverage the physician trust. Physicians are the primary influence on cure perception for 58% of patients. This underscores the responsibility and opportunity for oncologists to set realistic, hope-affirming expectations about depth of responses and long-term outcome. And now we go to the physician survey. So the physician survey on cure in myeloma, this was a SARC region cross-sectional survey of 103 respondents till date, but we have done the analysis of 96 physicians from 7 countries. 68% of them were clinical hematologists and 79% were from India and 42% were from the academic institutes. So the more than almost 50% of the myeloma physicians have experience of more than 10 years. There were 23% of physicians who had less than 5 years of experience. So do you believe multiple myeloma can be curable? So 66% of physicians believe possibly yes in a small subset of patients, whereas 10% believe no, it is not curable. So the majority of the SARC physicians believe that myeloma may be curable in a small subset of patients, reflecting a cautious evidence-tempered optimism. Only 23% consider myeloma broadly curable, while 10% remain unconvinced. Then which best defines the cure in myeloma? So most of the physicians said sustained MRD negativity, long-term remission in 40% of physicians said that, no evidence of disease without therapy, normal life expectancy, and disease controlled indefinitely. Then the next question was cure threshold, remission, duration, MRD, and treatment-free remission. So here, most of the physicians believe that, if They put the threshold as 10 years. I think this is aligned with what IMWG is also telling about that 5 years MRD negative status and probably 10 years. This is what the physician believe currently. 75% of physician says MRD negativity is sustained for more than 5 years. And treatment-free remission required, 66% says yes. The next question was practical parameters and conceptual framework of cure. Which single parameter do you use in practice to judge that the patient is approaching the cure? And most physicians believe, 50% of them, sustain MRD negativity. And the next question was, if the patient is on a continuous therapy like LEN maintenance, would you consider the patient as cured or not? So 53% of physicians said no. 28% of physicians said if the MRD is negative, only then they would consider that as cure, even if the patient is taking lenalidomide. Now, which concept best represent cure in myeloma? And 50% of the physicians said that they feel both functionally cure and biological cure, both concepts are valid. If they are there, then they believe that we can consider that as cure. Now, if a patient relapses after 10 years, even though the patient remains in remission for 10 years, and if he relapses, were they ever cured? So 44% of physicians said no, relapses precludes the cure. This is a strict view, as also highlighted by Dr. Munshi, and 25% of the physicians says depends case to case, and 29% of physicians said that yes, that they were previously cured. Now, the most important goal of therapy in your country, because this is a SARC perspective, because we were looking at the different barriers as I highlighted in the initial slide, that low socioeconomic status, social barriers, and access barriers, lot of barriers are there. So we asked the question, what is the most important goal of therapy in your country? The long survival, 83% of the physicians said is the long survival, deep remission, TFR, and cure. And the practical priorities when aiming for cure was affordable therapy. So this is very important when we talk of the newer therapies like CAR-T or bispecifics, that affordable therapy is the most important practical priority when we achieve for cure in low and middle income countries. And what are the barriers, biggest barriers to achieving cure? Again, this comes to the cost of therapy and limited access to the advanced therapies. So when IMWG is considering cure for the world, then they should consider for low and middle income countries the definition of cure, the cost of therapy, and limited access also. Now, who has the highest chances of cure? Which therapies can make cure possible? So 67% of the physicians said the patients who are transplant eligible with deep responses, sustained MRD negative, standardized cytogenetics, and patient treated early in the disease course, as highlighted by Colonel Uday in his 5-year and 10-mark analysis. Therapies that make cure possible, 56% of physicians believes that it is the combination of all modalities rather than only quadruplet, MRD-guided, CAR-T, or bispecifics. So in one sentence, we asked, this was a open-ended question, how would you define cure in myeloma? And different physicians from India, Sri Lanka, Pakistan, and other countries gave the different definitions. So physician versus patient perspective on cure. Believing multiple myeloma is curable. In the physicians, 66% subset said yes. In the patient side, 50% patients said yes. Top cure criteria, sustained MRD negativity. This is what the scientific definition is. Whereas from the patient point of view, if disease never returns, then they would consider that this is the cure criteria. On maintenance, would you consider the patient as cured? Only 8% said yes. Whereas from the physician, from the patient point of view, only 26% feel cure on treatment. TFR required for cure, physicians said yes, 60%, 66. Patient 74% rate being off treatment is very, very important. Controlled disease is equivalent to cure. Only 40% of physicians accept indefinite control as cure, whereas patients 53% reject control as equivalent to cure. The primary influencer in the physician obviously is evidence-based guidelines, IMWG definition, and MRD data, whereas from the patient point of view, the primary influencer on the definition of cure is the physician. The top practical barriers are the cost and access. The financial toxicity is very, very important from the patient point of view. So majority of the SARC physician believe multiple myeloma is curable, only in a small subset of patient. Sustained MRD negativity is the preferred cure criteria used as the primary practical that by 50% in daily practice, 75% require MRD negativity sustained for more than 5 years, and 66% physician believe insist on treatment-free remission. 53% of the physician reject the notion that patients on maintenance therapy can be cured even if they are MRD negative. Cost of therapy and limited access to novel therapies are the predominant barriers to cure. 56% believe only a combination of modalities can achieve a cure. And physician and patient prospective conversion on TFR and lifelong disease absent that are the clinical rigors of definition. So hence our regional consensus of operational cure criteria combining MRD directed therapy, TFR duration, and quality of life benchmarks are urgently needed to guide SARC practice and trial design. So finally, the acknowledgement. I must thank Colonel Uday Yana Mandra for analyzing the surveys and making these the slides, the physician slides. The colleagues in India, Sri Lanka, Nepal, Bangladesh, Pakistan, Maldives, Bhutan, and Myanmar. Dr. Gayatri from Yodhas and Miss Vinita Menon from Myeloma Friend Charitable Trust for patient-related survey, and my departmental colleagues, social workers, senior resident, and my ex-students.
Thank you.
Thank you, sir.
Thank you. Thank you very much, Pankaj. So that's what the physician was the science and the patient was the art, where science meets art, and the perceptions are understandable. But I must say a very exhaustive bandwidth has been covered in the questionnaire, which is, I would say developing country centric, though most of the things are available in these parts of the world, but accessibility is the issue. So we will discuss this when in the Q&A session. We move on to the next talk that's on the Asian perspective of cure in myeloma by Dr. Viju. And Dr. Viju also has been on our platform quite a few times. He is a professor in medical oncology in the National University of Singapore. And he's also, importantly, the chairperson of the Asia Myeloma Network Executive Committee. Dr. Viju, please.
Thank you so much for the very kind introduction. So I've been asked to talk about whether cure is feasible in Asia, and I had the opportunity to actually attend some of the sessions online. Unfortunately, I wasn't able to travel all the way across the world to the meeting, and it was very interesting. But just to say that this issue of cure versus control has been top of our mind in the AMN for several years. This was actually the slide that I used 3 years ago, where we have this as a topic of debate between myself and the late Professor Brian Dury. And it's precisely because I think we were on the cusp at that point to have the kind of tools and treatment armamentarium where we can sort of consider whether cure is a possibility or not. And I'm not going to go through this in detail because the prior talk has actually highlighted the difference. But just to highlight also, which has been agreed with other speakers, that even with very old treatment, we always have had small proportion of patients that are so-called cured within the cure fraction. The hope here with the meeting is that with these new tools that we have, can we increase this cure fraction to maybe the majority of the patient? And actually the ambitious target that is highlighted by Professor Munshi is a very ambitious target, right? But I think as with these other conditions like Hodgkin's, ALL, and so on, we need to aim high first, get the cure fraction high before we consider actually reducing the treatment intensity. Because always when you aim high, there may be a proportion of patient that is so-called over-treated. But that is actually not an issue when you haven't quite reached that yet. So that's kind of the philosophy of the group, right? And I took a few sort of concepts that was, I thought, most elegantly highlighted by Dr. Saga Lonell in his talk. And he talked about what is necessary for cure. And based on the definition that was proposed, these are the prerequisite: elimination of the clone. And as a surrogate for this elimination of clone, the best tool we have at the moment is MRD negativity. And they define it as a much deeper level at 10 to the power minus 6, not just minus 5. And then to show this elimination is this sustained MRD. And the question is, how long is long enough? And Professor Munshi showed very nicely some analytics that was done to show that 5 years could be a good benchmark. But this is even a higher bar that was defined because it's 5 years without treatment, right? So it's sustained without treatment. And I think that is challenging and probably only possible if you use very, very good therapy up front. And we'll talk a bit about how feasible that is in the Asia setting. And it's not just about a bone marrow sample or blood-based, but also on imaging as well. And do we have the tools? The answer is yes. And these were some slides also presented by colleagues during the meeting, because based on just upfront treatment with the Perseus data, we're seeing such high level of sustained MRD negativity, about 50 to 60%. And in these patients, you're seeing very flat PFS curve, right? Going up to 48 months. So that's certainly very, very promising. And based on the projection done by J&J on the Perseus and Cepheus data, and of course, this needs to be taken with a slight pinch of salt because this is long-term projection based on modeling. With the Perseus regimen in transplant-eligible patient, we are potentially seeing a 17 years PFS. So this is no progression in 17 years. And that's how effective it is. Then you fast forward to more recent reports like Majestic Tree, and this is in relapse patient. You're seeing this kind of survival curve that is quite flat, going out to 36, 40 months, right? 83% of patients are progression-free at 36 months. This is fairly unprecedented. So, you know, when you consider the T-cell engager, which is in Majestic Tree, and it's even working in high-risk patient, right? Because I saw a question online, should we exclude cure as a target for high-risk patient? In truth here is that you see progression-free survival, even in high-risk patient, that is at 80-something% if they can get MRD negativity. And then we have already seen the CARTITUDE data with cilta-cel in multiply relapsed patients. We're seeing third of patients having progression-free at 5 years. This is, you know, remarkable. So we have fantastic tools. And when we bring these tools to the earlier line, like cilta-cel in first relapse LAN refractory patients, we are seeing also very remarkable, much better results than actually in CARTITUDE-1, right? So when you bring these tools up front, the effectiveness is great. Then the other thing is avoidance of continuous therapy. Why? Because, you know, as seen in the patient survey, they feel like it's more like a cure if they're not on treatment. And more importantly is that the continuous treatment often will induce drug resistance. So by avoiding that, you avoid drug resistance as well. And I thought this is very elegantly illustrated by, again, slide used by Saga, where he showcased that myeloma, the problem is that you have multiple clones. But these clones may have different vulnerability and different targets. If you just use one treatment, you're always potentially going to select for some resistant clone that is very small in numbers, maybe even below MRD level, that may be a cause for future relapse, right? So this concept of rotating treatment to trying to target different targets in the different residual clones so that you achieve complete clonal eradication, I think is biologically and conceptually very attractive. And this was what he said about the future: combination sequential treatment, switching targets, not treating to resistance, limited duration of treatment, and all the backbones effective drug will be used and is not dependent on a single target. Actually, if we think about how we treat ALL, where we use different phases of treatment, different combination of treatment, this is akin to that kind of approach. And in fact, going back to how Bart Balogi started the total therapy tree, that was his idea, actually, is to treat myeloma like ALL, except that he doesn't have as effective a set of tools as we have today. So the key issue for us in Asia is how to get access to these drugs and the cost of treatment. But actually, if you think about it, if we have availability of the quartz, which I think in India you already have, and for many countries, right? And then if you think about Majestic Tree, just with Dara and T-cell engager as a second line, you potentially have a PFS exceeding 20 years there, right? And how to use this optimally. Then I would say, as my last slide, that although cure is a great target and objective, if we try to achieve cure, even if we fall short of it, we are probably getting a large group of patients into functional cure. And what I mean by this is that is it such a bad thing for myeloma patient to die of another disease, not of myeloma? And some of these patients may still be on treatment, some of them may not be on treatment, some of them may still have small amount of detectable disease, some of them no detectable disease. But what is important is that they have life expectancy like a normal age-sex match population. And I think this target is really very achievable. To have the very strict cure definition in Asia, I think that may be a bit more challenging compared to maybe in the US, but nevertheless, I think it is a good target to aim for. So with that, thank you very much.
Thank you, Dr. Viju. That was very interesting to actually give the practical aspects, taking into consideration the limitations in our part of the world, and also giving your point of view, taking the extracts from the summit. But I think that was very interestingly put forward, and I think we all enjoyed your talk. We go on to the next by Dr. Chandramouli from Singapore General Hospital on the 5 and 10-year landmark analysis from Asian multi-country database. And like I said, most of the people have already participated in our platforms. So Dr. Chandramouli is very active in this field, and he actually is a senior consultant hematologist in the General Hospital and is currently the head of the Singapore Health Duke NUS Blood Cancer Center also. So can we have Dr. Chandramouli, please?
Thank you very much for the kind introduction, Chandranaya. Can you hear me and see my slides as well?
Yes.
Thank you. Great. So unfortunately, I don't have the kind of landmark analysis that Uday had asked me. So I do have data on the Asian myeloma patient group from quite a few number of Asian countries from a registry. So that is what I would be sharing today, with some glimpses of what might potentially be relevant for the long-term cure fraction that we talked about that I'll present later. So the data has come that I'm going to share today has come from the Asia Pacific Myeloma and Related Diseases Registry that is hosted under the auspices as an IIS under the Monash University, led by Professor Erica Wood, based at Monash, and is the primary investigator being Professor Andrew Spencer. This was established as a prospective registry back in 2018, and as of today, or a few months ago, we had 30 active sites recruiting patients from across 5 countries and regions with respective IRB approvals, and have thus far in the last 8 years accumulated more than 3,500 patients on this registry. The respective sites that are recruiting patients are mentioned in this map here. But the beauty of this is this registry is not just capturing myeloma patients, but as we all know, there is not a lot of data on the precursor plasma cell disorders from Asia, as well as data from plasma cell leukemia and such diseases like solitary bone or extramedullary plasmacytomas. And I really look forward to the data that has come out of this, that is going to come out of this registry in the future on these diseases. But for today, we'll restrict ourselves to talking about myeloma. Now, a couple of things that I would like to stress on the patient and myeloma disease characteristics here is one of the things that was captured in this data, in this registry, was the patient self-reported quality of life questionnaire as a visual analog scale at the point of diagnosis. And it clearly seems to be mirroring, for example, in Malaysia, patient feeling worse on a scale of 0 to 100, 100 being the best state and 0 being the worst. The 0 being the worst and 100 being the best state of health. Higher number of patients with ISS3 in the patients who are coming out of Malaysia seems to correlate with the higher severity or worse, how worse the patients feel. From data of patients recruited from Singapore in this database, we see that not only we have higher proportion of patients who are older in our database, but also patients who have a large majority of patients having higher comorbidities. And this is something that is reflective of my own clinical practice in Singapore. Couple of features on the myeloma characteristics that I would like to bring to the attention of the audience here is we do know that there seems to be a higher incidence of IgD myelomas that is coming out of China, but there is also a closer look that is being paid attention to In terms of free light chain, pure free light chain myeloma in Asia, that seems to be of higher incidence, particularly in China and Taiwan. The top 3 regimens, as is reflected on this slide from across the different jurisdictions, 2 things that we can recognize is 1, VRD. During the time when the patients were recruited into this registry, has eventually become one of the top 3 regimens, and in fact, the most commonly used regimen across many countries represented in the registry, with a smaller proportion of patients still having received, who are part of the registry, who joined the registry earlier on in the course of the years, receiving VTD. But there is also an increasing representation that is being noted is the addition of daratumumab, particularly from China, who only recently joined this registry in the last few years. And there's a lot more patients receiving daratumumab. One thing that was quite heartening to see is virtually most patients who were less than 65 years old receiving autologous stem cell transplant, which in Asia is still remaining a cornerstone of therapy, not only in less than 65, but more so in also in 65 to 70-year-olds. And at least in Singapore and Korea, more patients in the more than 70 years, despite the older age presentation, as well as the comorbidity numbers that are seen in these patients. And this is again reflected in our practice. We transplant most patients beyond the age of 70. The second point is also the number of responses of the top line overall responses, as we know, declines with the number of subsequent lines of therapy, essentially dropping by about 20 to 30% with each further lines of therapy. In terms of first-line responses to first-line therapy, it is quite good to see that more than 65 to 70% of patients achieving at least a VGPR or better to the combination of bortezomib as a key proteasome inhibitor in the first-line therapy with either thalidomide or lenalidomide, which is in keeping with what we would expect in these patients. Now, in patients who haven't received transplant for whatever reason, the top 3 regimens that have come out, once again, is VRD, which is becoming a standard of care more recently in the jurisdictions represented here. Some centers do have still using VMP, for example, in Korea, as well as more recently the inclusion of daratumumab, particularly in Singapore and China. When it comes to maintenance therapy, one would think that it should be an open and closed case in terms of using lenalidomide uniformly. But when we come to real-world registries like this, there is a demonstration of difficulty in access as maintenance therapy, across the years from 2017 to 2018 onwards. And hence, we don't see uniform adoption of lenalidomide. But what is heartening to see is the patients who receive lenalidomide at maintenance, the good practice point of dropping the DEX when it comes to maintenance is reflected here, which is quite a good thing to see. So vast majority of patients who are receiving lenalidomide don't have the DEX, but there is also a number of other drugs which are being used, for example, thalidomide and Velcade, which are also represented in this maintenance therapy as a top 5 regimen. Now, the most common second-line therapies that are being used in these patients, once again, you see a lot more use of bortezomib and lenalidomide, but also a number of patients now receiving daratumumab, as well as carfilzomib being one of the top 3 regimens that have come up on this, mainly on the back of the number of patients who receive this as a primary regimen for first relapse in Korea, which is, essentially representing the large proportion of this registry. Now, when we come to progression-free survival, I was looking at what Dr. Munshi had presented earlier from European data. And as you can see here, the PFS after first-line therapy here is pretty much comparable to what was reported in myeloma 11 in the younger patients. And when we even think about some of the more recent data presented from Europe and US, it's pretty comparable across the APAC region as the median PFS. Now, one of the advantages of the APAC registry has been the sister registry in ANZ, which includes Australia and New Zealand, which started more than 6 years prior to the APAC registry having started. And as you can see here, the PFS rates between the 2 registries were pretty comparable with Australia and New Zealand being represented in the interrupted blue curve as well as the red dotted lines. And the PFS data is really comparable across the two registries. This slide demonstrates the overall survival of the whole cohort on the left, and once again comparing the overall survival in the APAC region on the top, and comparison between APAC and its sister registry in ANZ in the bottom. Now, the overall survival in the APAC region in the registry has not been reached, but it seems like it is comparable to what we see in the ANZ cohort. Now, I know we wanted to talk about cure in this, but what we do find here is up to a third of patients haven't even reached a 3-year overall survival in this registry. And the main factors on the multivariate analysis that was noted that were associated with very poor survival was age more than 65 years, poor performance status at presentation, a lower platelet count, lower creatinine clearance, high LDH, perhaps most of which reflect a high disease burden as well as high-risk genomic features, which also is not surprising. So my final slide on conclusions. So based on this prospective real-world registry, it appears that Asian data is comparable in terms of progression-free survival and overall survival. As I have mentioned, when we even compare it to the ANZ registry, a third of patients seem to have very poor short OS, which is the key unmet need population. That can be gleaned 10 to 15% of long survivors in this cohort of patients. And we should and are planning for a deeper dive into this population to understand the characteristics of this patient population. It's quite heartening to see the continued use of ASCT at this point, but whether a new trend is going to emerge as the CD38 use early on in the upfront treatment, whether that is going to change the ASCT use is something that will be interesting to see. But it also stresses the point, when we see some countries like Malaysia, where the access to some of the drugs is even more challenging than some of the other countries, it is crucial to continue to work on improving access and availability of the emerging therapies. And finally, all this data presentations would not be possible without the members projected here, the steering committee of representatives for all the countries and regions that recruit patients into this registry, the team, the registry team, headed by Professor Erica Wood of Monash University, Andrew, who leads the registry, and Cameron, the statistician for the registry. And with that, I would like to say thank you to all for your kind attention.
Thank you very much, Dr. Chandramouli, and I must compliment you on a very short time that you had. You put together great data. So obviously, I must say compliment the whole team. Thank you very much, and I'm sure with time you will have more of the data added to what you've shown us. But that was very interesting to see the heterogeneous approaches upfront and for maintenance. So with that, we go to the last talk. That is studies to be planned in Asia in line with cure in myeloma. This is by none other than Dr. Shaji Kumar, who again needs no introduction because he's been a constant part of all our image activities here. But still, it'll be important for me to say that he leads academics and research in so many fronts. And very often I feel he does wear many hats. And he presently, is in Rochester, in Mayo Clinic, Rochester. And we are looking forward to hearing this talk from you on how to carry this forward. Dr. Shaji, please.
Hi, Lou, thank you so much for the introduction. I'm not going to try and say what needs to be done in Asia. I think that's what I think we all have to, as a group, decide what are the things that can be done and the ones that are going to be most productive. What I have done is just kind of put together a couple slides just to bring up some of the points for discussion. Hopefully you can see these slides. So again, let's see if we can. Are you able to see this?
Yes.
Okay. A lot of nice data discussion so far. I did miss a few minutes in between. I had to jump off the meeting for another meeting. So let me just, So two things, right? One is there's no doubt. I mean, this is just one representative curve, but there are many such, and similar to what has been shown from multiple databases, including the ones that Uday presented and Chandramouli presented. So there's no question survival has improved. As Nikhil said in the beginning, clearly we have a higher cure fraction, especially with the newer therapies. And we talked about functional cure. And it's very clear that we already there with functional cure, right? Even when you look at some of the patients we have treated at Mayo in the past, if you look at patients who are ISS stage 1, who is over 75, which is kind of that blue line on the top, and the dotted line is the expected survival, you can see two things. One, there is a subset of patients who have expected survival without necessarily meeting the strict biological definition of cure that we talked about in the beginning. And so this may be a little bit more of the statistical sense. And when you look at the subsequent year period, you can see that that percentage has gone up a little bit more. So clearly there are subset of people who are dying who get diagnosed with myeloma, who get treated for myeloma, but don't die of myeloma. So I think what are the questions that we want to try and answer, especially when you talk about the Asian setting? First of all, I think it's important we need to independently verify what exactly is the cure fraction that we are seeing right now with the current therapies in the Asian population, because that's going to be the benchmark for future, right? And one could ask, why do we need to redo the same work again? Because there's significant differences. We can't just assume that it's all the same. We already know there's ethnic racial differences in disease biology. We know the treatment responses are different. We know the treatment toxicities are different. And toxicities are also important because at the end of the day, that determines whether patients can get the kind of intense therapies that we are proposing for the duration that we think they need to get it. And then life expectancy is different. And that has significant implications for functional cure, but also for the biological cure that we talk about, because, in terms of for a given patient, what do we aim for has to be taken in the context of life expectancy. And then, of course, treatment access is different, even though that continues to evolve. And the other thing we need to also answer is, has the cure fraction actually improved over time? And based on everything that's been presented, my assumption would be it is true that it is improved over time, but how much? What is the magnitude? Because treatment access has changed over time. There's more access to the cutting edge therapies than it ever used to be in the past, even though it may be applicable or accessible only to a small fraction of the population. And one thing that I think is often underappreciated when we talk about all the improvements in care has been the supportive care. And this is particularly relevant when you talk about infectious disease complications in the Asian setting, and is going to be even more relevant as we start talking about immune therapies. And I think some of the cutting edge technologies have become more available over the past decade in the Asian countries, as well as Viju already alluded to in his talk. So what can we do, right? I think about it as two things. One is, what can we do with what we have? And I think we got a glimpse of that from what Uday presented and what Chandramouli presented. We have wonderful databases. Can we make it better? Can we get a large registry studies? The biggest challenge that I see with respect to estimating cure fraction is that we probably don't have a good denominator. I think we have a good denominator in terms of what we have been able to collect, but that is not necessarily, when you're talking about fractions, you really need a very robust denominator. So I think it's important for us to continue to build on what has been done to expand the reach of these registries, but also important to see how we can incorporate some of these advanced techniques for disease assessment. I think in order to improve that, we really need to have a better and a more proactive follow-up. I think loss to follow-up is a big challenge in the Asian setting, I believe, and I think many of you highlighted that already. And then using these, we also need to identify what are the disease and host characteristics that do predict long-term survival based on what we have right now. Because, in the end of the day, we may not be able to target everybody for cure, right? So there might be some patients who have the maximum possibility of getting a cure. I think we need to focus the limited resources to those patients to get into that biological cure. There may be people who are functional cure may be the best approach, either because of their age or their aspirations or what the resources are available. So we need to identify where we can achieve that. And then there may be certain places where we are still at the control stage, some of the high-risk diseases and some other characteristics of host and disease. And we need to be more realistic about what we can do. And finally, is there a functional cure? I think, as was pointed out by Viju, I think this may be more relevant for the Asian setting in the shorter term. It is not necessarily, we always want to shoot for the best, but we also want to shoot for what is going to benefit the maximum number of people. I think that is important, especially given the difference in life expectancy across the globe. And again, the treatment access being limited both for availability and affordability. So what kind of studies should we do? I think we had to focus on three, themes, I would say. One is the retrospective registry studies are good, but I think we need to actually design observational clinical studies where we can incorporate on a systematic basis the new technologies for imaging, mass spec, and other next generation sequencing and so forth, with very rigorous follow-up. So this will require a fair amount of commitment so that these patients can be, we can reach out to the patients, make sure they are followed up on a regular basis, make sure they get the tests that they need to. And some of these things like mass spectrometry potentially can be done even on, there have been, in attempts going on trying to see, can we do things like blood spot to do mass spec on, which may allow us access to even, patients who cannot come to the clinic on a regular basis. The second thing I think we need to do is to kind of really prove that we can cure some patients in the Asian setting as well. So, designing small trials, right, where we can do everything that needs to be done, both in terms of the types of therapy, in the types of follow-up, and these are going to be, not for everyone. These are going to be very selected patients, but we want to show that they can actually do that. And then I think we need to continue kind of more of that risk and frailty adapted approaches, particularly in the setting of limited resources. So I think it's, I think the key thing is use the existing data and maybe to some extent what we can collect systematically to identify where should we be focusing our energy on, or kind of, it's not more the risk adapted trial, it's more the kind of the resource adapted trial in terms of the maximum benefit, maybe a smaller cohort, then a broader benefit in functional cure in a bigger population, and then identifying where it may, it may be more of a control approach. So I'll stop there and just open it up for discussion.
Thank you very much, Dr. Shaji, for those, very good ideas, which I'm sure, we will try and take forward as a collective effort. And they are, I think, eminently possible in most parts. Of course, the newer tools are not accessible across the board, but many of the things that you said are already being done. But, again, it's organizing, having a structured approach, having the correct data collection, having the basic support that we need to do these things. And like you said, we should be very clear in our mind that what are the cure fraction that we are looking at in this part of the world. And, really speaking, with the older treatments and the present treatments, we already have a cohort where we can say how much it's improved. That itself is more measurable. And follow-up, loss to follow-up is a practical problem, but I'm sure that also is improving with many of these, digital follow-up techniques that are being followed in various centers. And what studies we do, what you said is very practical. And I think, we have done very well. And I want to thank each one for exceptionally giving, enriching and forward, looking ideas. But having said that, we have about 15 minutes more of time where we can have some ideas from the rest of the panelists here, and then we can sort of sum it up. So I can see some more people here. Professor Hari, anything from you would like to say? Quick ones. You're muted.
Yeah, it was an excellent update and also a great concept to actually look forward to. We have always been, and Pankaj survey echoes quite a bit of what myeloma physicians would think about in terms of what is the path towards cure. And I think we are all very much aligned in that respect. And I was quite happy to see in the survey that many people think alike, and that would be the path to go towards looking at cure, or at least for the subset of patients. And more importantly, we know better therapy delivered initially in the best possible way is increasingly the way forward to deliver. And we should look at ways how we can deliver optimized therapy for our myeloma patients in order to achieve the target of low disease burden and eventually to MRD negative status.
Thank you. Thank you. You know, what amazes me is what, Professor Nikhil said in the beginning. You know, he quoted in the summit itself and thereafter showed data from B-cell malignancies to the stories of lymphoma, Hodgkin's lymphoma and the likes, and then coming down to basic hypertension and diabetes. So I don't know why we took so long to actually think that we also have a curable fraction, because that last part of the graph was always available for us to see. But I must congratulate you for having taken a foundational approach to tickle the minds of all around you to think differently on what existed already. So that's a great thing. It's more easily said than done, but I must say, and I must congratulate. I sometimes wonder from where Uday gets all his energy. So sunlight, yes, but from where else I don't know, because he just came back from the summit and he was bubbling with the idea of this particular meeting. So I thought it was very ambitious, but there you are. If there's a will, there's a way, and you'll find a way to do it. And he's got a global, flavor here, and he's persuaded, from Dr. Viju to Chandramouli to actually do these presentations in a short time, and you've done in exceptional way. You all have presented your data, and I think the concept of cure in multiple myeloma has definitely evolved from a philosophical aspiration that we talk like castles in the air, to a measurable clinical goal, as you have shown today. And that's the most important part, whether it's sustained MRD negativity, imaging remissions, or treatment-free survivals. But putting all of them together, you have made it very objective, and like we are already doing it. But to put it together in a structured way and to say where do we stand is the goal right now. And I'm sure this subset of patients will increase, because even the diagnosis is occurring earlier, even in India. It was very dismal, but like there was nobody before the IS3 who even came to us, and all had end organ damage. But that is changing, and in many parts of our country, let me tell you that. And at the same time, we do acknowledge that there are real world challenges of excess affordability and the variability in diagnosis. It's a little heterogeneous, but I'm sure once we talk about this and we all collectively approach this, this concept will translate into practice. And I think that is the important part. So cure is not just a biology, it is about equity, access, and thoughtful application of science. And I think we are very much on that road, and that's where a collaborative effort in Asia is very important, because like everybody said, why are we different? How are we different? And why we should have actually our own data sets to actually make decisions in again a collective way. And with those, I think I would like to tell you that we had more than 200 people tuning in to this evening, people from more than 22 countries, and right across the world. We've had people from all countries, some of them who have never been on our platform. So I'm very happy that we could do this together, and I look forward to carrying this forward to a next session where we actually can have more ideas, more brainstorming, and I'm sure we'll have lots of light at the end of the tunnel. So with that, if nobody else has any, Dr. Nikhil, you want any, you want to sum up, say something more, you're welcome.
No, this is, I think, wonderful gathering and discussion. I was very heartened to see the attitude of patients and physicians in our part of the world, that they do believe it is curable. And I think when they do believe in that, I think we will get there. So you summed up well that we are curing, and we just need to identify. I think Uday and Pankaj and everybody's effort to get the data is a wonderful effort, as Shaji suggested. And last thing I would say, don't lower the bar. We can cure and we need to cure by the strictest definition. Yes, we'll go for control, we'll do for other things. Don't lower the bar. We are as good as anybody else. And yes, we have constraints, but within that constraint, we can achieve what we need to achieve.
Thank you very much. And I want to thank each one of you for your time in the morning and in the evening from various parts of the world. I can only say, long live patients with myeloma. And I'm sure, we will meet again very soon. And a big thank you to Uday and Pankaj for having made this possible. Chandramouli and Biju for having joined us. And as always, Professor Nikhil and Shaji for having supported this venture. Thank you very much. A very good evening to all of you, and Jai Hind.
Thank you. Thank you.
Thank you.
Thank you, sir.
Thank you.